Good morning, everyone. Thank you so much for joining us at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Be Well Texas and the Center for Substance Use Training and Telementoring. My name's Andrea Roche. Great to see all of you here today. I'll just be facilitating our conversation throughout the session. I want to start, as people are entering, with just a few quick housekeeping notes. Please help us with attendance. To do that, you can enter your name, affiliation, and email into the chat. Thanks to those of you who've already been doing that and being role models for everyone else. To access that chat feature, navigate to the bottom of the Zoom window and click on that speech bubble icon. If you've joined by phone only, I want you to please take note of this message, especially if you're a Be Well Texas provider. Make sure you identify yourself during the session. If you can't do that in the chat, if you join by the phone, then email your phone number and name to the Be Well Texas team at bewelltx@uthscsa.edu. That allows us to make sure your attendance is noted for the day. ECHO IT is going to put that email over in the chat too. As you saw when you entered the session and when it started, this session is being recorded for later distribution through the Be Well Texas YouTube page. Know that any information you put in the chat is not going to come up on those recordings. I also want to point out that these sessions are enabled for live closed captioning. So if you'd like to view closed captioning for this session, just navigate again to the bottom of your Zoom window and select the Show Captions option. You might need to click on those three dots over to the right or that More menu on the bottom right corner of your Zoom screen to find the option. If you're having trouble accessing the captions, just please chat ECHO IT. We encourage everyone to join by video for the discussion portion in the later half of the session. That said, if you've joined up to learn with us, we're happy you're here. Please do, though, stay muted unless you're speaking, and we do encourage everyone to speak today. If you joined on the computer, mute and unmute are the controls on the bottom left of your Zoom window. If you're on the phone, press *6 to mute and unmute. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate you have a comment to share. You really only need to do that if there's a lot of conversation going on at once. And you can also always use the chat feature to share your perspective. There are a lot of us in this space and the numbers keep popping up, which is awesome, but it does serve as a good reminder to keep our comments brief to allow others a chance to share as well. And finally, please note, no protected health information is allowed in the chat or in our discussions. Keep an eye on that chat. Towards the end of the session, the Be Well Texas team is going to send out a link to an evaluation survey. So please fill it out to give us some feedback on how we can shape these sessions moving forward, and to also access free continuing education. Right now we have CEs for paramedics and public safety professionals with a behavioral health degree like social work or counseling credentials. If you are looking for other forms of CE, go on and fill that survey out and let us know what you're looking for so that we can adapt and respond to that. And then last, if you fill out this survey, you're entered into a drawing to win a $30 Walmart gift card. So please do give us your feedback. Okay, so today's session, we're going to get started with it. We'll go with a presentation first on effective communication in community corrections settings. And then following that, we'll hear a case presented by Dr. Andrea Yatsko at UT Health Houston. And I want to thank you all for joining us in today's ECHO. I encourage you to join the conversation of the case presentation after that happens about midway through the session. We're all learners, we're all teachers in this space. So I encourage you to share your experiences and your questions and your insight into our conversation. Before we get going with didactics, let's just do some introductions of our hub team. I'll start with you, David.
Hi, I'm Dr. Dave Miramontes. I'm the medical director for San Antonio Fire Department, and we do a lot of work in this space, including a Suboxone induction.
Great, thank you. And Cynthia.
Hi, I'm Cynthia Mendiola. I'm a retired federal probation officer, and I work with Correctional Solutions as a coach and trainer.
Thanks for joining us, Cynthia. And Jeremiah.
Hi, everybody. I'm Jeremiah Golka. I'm Executive Director of the SHIELD Training Initiative, which provides safety and health training for people across the public safety space.
Thanks for joining us. Adrian.
Hi, everyone. Adrienne Lindsay, Director for the Center for Substance Use Training and Telementoring here at Be Well Texas.
Thank you for joining us today. And Andrea.
My name is Andrea Helder, and I am a program coordinator with ECHO and CSTAT. Happy to be here.
All right, thank you so much. And Andrea, I'll also ask you to introduce yourself as our case presenter for today.
So many Andreas on this call. I love it. Hello, everyone. I'm Dr. Andrea Yatzko. I'm over at the UT Health Heroes program and very excited to be here today. Thanks for having me.
Thank you. All right, we're going to get started with our didactic. Cynthia, when you're ready, go on and share screen and take it away. And make sure to enable sound when you share screen.
Okay, can everyone see that?
We do, but it looks like you might need to swap your displays. So up at the top, you should see something that's like, I think it's swap displays or display view, right about where your mouse is. Yeah, if you click on that, do you see something that says swap displays? There you go. That exactly, click that.
Okay. Okay, because usually I'm used to the other way around. So this,
And
thanks everyone. Huh?
It still looks a little bit off for me. Can you try that one more time? Go up to display settings
Okay,
and then swap presenter and slide.
I did. What do you see? My notes?
No, yeah, we see the notes on it.
That's weird.
I'd say go on and minimize. It's interesting. It's not what we saw in our test run.
No.
I'd say minimize it. Stop your screen share. Cynthia, are you working with two desktops in front of you?
I don't know.
Oh, or two, not two. Yeah, are you working with two computer
Oh,
screens?
yes, I have two screens.
Okay, try next time you share, bring your PowerPoint slides over to the other screen. This has worked for me before.
Okay, let's see if this is it.
This looks good. And I hope when you were quickly doing that, you clicked share computer sound. You might not have done that. Did you?
Yes.
Okay, awesome. Take it away.
Okay, sorry about that. Technical
No problem.
difficulties. I'm not that savvy, but thank you for being here. And one of the things that we're going to be talking about today is some of the learning objectives is just some brief overviews of what participants will be seeing today in learning. One will be just an overview of principles that support the core correctional intervention strategies used in the community supervision setting. Participants will also learn about relationship and bridging skills, most effective to engage in substance use disorder, clients with substance use disorders in promoting change. And then if we have some time, I'm hoping we do, we'll provide an overview of the cognitive model skill used to help justice-involved individuals manage their substance use and or their risk behavior. So before we go into some of those skills, we really need to look at some principles that are pretty much overarching on a lot of what we do in probation, and we want to train officers to continue to do. And those principles are called the R&R principles. And basically what that means is risk, needs, and responsivity. These principles came from research from back in the 1990s and moving on to today. And it's a lot of the research from it's called the What Works research that comes from the Canadians, Don Andrew and James Bonta. And what they discovered is that in all of the work that was done in research is that treatment does work to help and rehabilitate individuals under supervision or in the corrections setting. And that it's important that there are certain types of treatment modalities that are best and most effective. So, again, this is a training in and of itself, but basically what the research came out with was that these principles, the risk principle indicates that most of the work is concentrated on the moderate to high risk individuals under supervision. And what we target are the needs, or what we're called our criminogenic needs. These needs are dynamic risk factors that are able to be changed if we target those need areas and intervene with appropriate interventions. And so the last part of this principle is the responsivity principle. And when it came out, the research came out, it was a general responsivity, which the research showed that the best and most effective treatment modality for individuals under the criminal justice setting was cognitive programs, CBT programs, and those were the best and most effective. So with that information, more and more researchers built on that. Don Andrews and James Bonta came up with the actual determinants of recidivism, which is really important because once you find what are the determinants of recidivism, those are the areas that you really need to concentrate your work in. And this was really difficult for probation officers to understand and to take in because they were used to recognizing, someone was unemployed, work on the unemployment, someone had a substance use disorder, only work on that. And but what was really important was that once we found what areas that really were the most important and the most influential areas to help someone not reoffend, then that was really the most important and key area to work on. So if we look into the next slide, we can see that this is really more of the driving area that officers are working in or should be working in, and it's called the need principle. And this is identifying the person's criminogenic needs. I call them dynamic risk factors, criminogenic needs. And this is targeting them in supervision contacts, and it's also by teaching skills and using interventions in these areas. One of the most important things that came out of the risk is that the top 3 criminogenic needs is antisocial attitudes, values, and beliefs. And the second one is antisocial peers. Third one, antisocial behavioral patterns. So if officers are working on the substance abuse category at the bottom only without paying attention to any antisocial attitudes, values, and beliefs, then you're missing part of what are the areas that you can really work on to help someone change. So for the purpose of time, we'll only focus on the need principle and look at some of the areas that need to be identified. And like I said, most of the time, the ones that are most important are the top 3. And I'm not saying that you don't work on a substance use disorder. We do, but if you look carefully at a substance use disorder, you also have a lot of antisocial attitudes coming out, a lot of, I call them drug-related beliefs. In other words, they're beliefs that have eventually become distorted and now support some drug use, or even individuals that are in the environment of either trafficking drugs or using drugs, and so those are with antisocial peers. So those are some areas that officers are working towards to evaluate and go in much deeper. Okay, so knowing this, then we look at 4 important content areas. Community supervision officers learn skills in each area that corresponds to as I just talked about, the R&R principles. So starting with the relationship skills, relationship skills are the supervision alliance, and relationship skills are active listening, giving feedback, and a skill called role clarification. And the next skill, and I'm skipping identifying targets for change because that is a tool that is officers are trained to help them identify what are some areas, some targets that correspond to those criminogenic needs that would be an area to change. And we move into the bridging skills, and these are called bridging skills because what we do in these areas is help bridge from establishing a supervision alliance, a collaborative relationship, into and working with individuals under supervision so that they would be receptive to receive intervention skills, to learn about how to use intervention skills. So the skills under the bridging skills is effective use of reinforcement, effective use of disapproval, and effective use of authority. These two areas, and really the bridging skills and the intervention skills, are most important when working with individuals with substance use disorders and also high-risk behavior. So let's look at some important principles in effective communication with individuals on supervision and individuals with substance use disorders that are on supervision. And this is motivational interviewing. And I'm sure many of you have heard the buzzwords, motivational interviewing. These principles are widely used in the social service field, the medical field, and community supervision. These principles come from extensive training and strategies. And today, of course, we're just going to do an overview. But in your interactions with individuals in the community supervision, it's important to have expressed empathy. You know, this involves one, to accept and understand the client's perspective, you know, having non-judgmental attitudes, and one without blaming. This is, I'm sorry, I'm doing it myself and I messed up there, sorry. And so it's important, and this is very difficult sometimes for probation officers, and I'm a probation officer as well. You know, it's sometimes difficult to have that type of perspective if you're trained in a field that has always been primarily an attitude of just law enforcement. So with that, we move on to developing discrepancies. And what do we mean by that when we talk about developing discrepancies? When we look at an individual and some of the things that are going in that person's lives, there is always a way to create and amplify a discrepancy between a behavior and their personal goals. And so when we'll go back and talk about how important all of these parts or stages of skills are used, we can see how officers can gain so much information from just getting what the personal goals of an individual is, you know, for supervision, beyond supervision, or for life. Recognizing that a client is ambivalent about an issue, so that helps in avoiding argumentation. So if we look at, you know, you recognize that somebody just is not sure they want to move forward or not, and there are so many factors that come to play why someone can't move forward to change or not. And so when someone firmly is taking one side of it, it creates defensiveness and taking one side. And I'm sure a lot of probation officers can identify with this, because we tend to know what is best for somebody and what we feel, how we want them to go, so that, you know, they don't reoffend. But it's not about us knowing, it's about that person coming to the realization and the awareness on their own in order to change. Rolling with resistance is another area that tends to be present in the community corrections field. It's really difficult because we do get a lot of resistance from individuals, and again, it's acknowledging this is something natural and it's understandable, and it's hard for probation officers sometimes to do that. It's also a key, or it shows that I'm sorry, I lost my train of thought, but it also shows that, you know, if you're having some argumentation, or if there's some defensiveness, it's also a way of knowing that that person is just not where you are at, and we really need to be where that person's at as far as their thoughts, their stage of change, where they think they need to be. So that if we try to impose our own views or goals, it becomes problematic. There are several strategies to help with, you know, developing discrepancies, rolling with resistance, avoiding argumentation. And a lot of that is using and reflecting back the individual statements of resistance, and ultimately remembering that it's a cue that the client's view is very different from what is being discussed. The last one is support of self-efficacy. In this area, you work on the client's belief, on the possibility of change. And so this is really important because it's not what you think is the person can change with, or it's about how this person believes that they can move on. This has to be real to them, and it's solely the responsibility of the client to choose and carry out that personal change and no one else. And so this is a little character that I have been carrying around with me since the 1990s. And I always use it. I always say, you need to find the carrots. You need to find the motivators for individuals. And some of the motivational interviewing strategies that are really important is, number one, ask open-ended questions. Instead of looking at someone and giving them questions with yes and no answers and coming across like interrogating. So the use of open-ended questions leaves so much room for a client to talk rather than responding to a yes and no question. Of course, we know that. And it's highly effective in getting as much information from someone when you use this strategy. And the other strategy that's part of motivational interviewing is listen reflectively. And I mentioned a little bit earlier is reflecting back someone's statements, or even remembering something that a client or a person on supervision talked about in your first interview or encounter, and reflecting back some of those statements that you remember. So listening reflectively is a form of sharp attention and restating the meaning of what you have heard from a client. And it takes a great deal of skill and training. This is another training in and of itself, just to learn how you can work through this. But there's simple reflecting that can be used that still reinforces some of the strategies and of motivational interviewing. And then we have affirming. Affirming is letting the client know that you hear and acknowledge the challenges or their experiences. Is that it's really important. It's not, affirming is very different from telling someone that you're proud of them. It's more about acknowledging what they've accomplished or what challenges they're going through and how they're getting through those challenges. The next one is eliciting self-motivational statements. So you use a guiding strategy to help clients through their ambivalence. You elicit arguments for change from clients instead of you providing statements yourself. So you try and work it in a way to where instead of you telling someone what motivates them, then you're eliciting from their own discussions what are their motivational motivators, intrinsic motivators. And I'll call them, what are your carrots? What are the carrots what are the things that you're going to accomplish from this motivation? So there are four categories, just really quickly, of self-motivational statements. And there's the categories you can find in problem recognition, when somebody finally recognizes that there's a problem, an expression of concern, there's an intention to change, and then optimism about change. So let's look a little bit at, let's listen a little to an individual on supervision and see what he says about his relationship with someone, probation officer. But before I move on, I just want to reiterate that Bill Miller, the founder of MI, says that the spirit of MI is to recognize and respond to change talk, and that's the most important thing, and to elicit. Ultimately, the last strategy is just summarize the discussions and that you've had with an individual, and bringing everything all together into a summary. So let's listen at the next recording of a client who's trying to establish what he thinks about establishing rapport in a relationship with a probation officer.
You go to see your pro officer, and the first thing comes out of his mouth is what you got to do or else, like club me over the head. I really feel that, this is just me, that once a person meets a probation officer, he's got to at least have some kind of communication and trust skills. You can't look at me and tell me, oh, I'm your probation officer and you're going to do what I say, or else, you know, like, that don't work no more. They need to talk to them instead of just, these are the rules, I'm your probation officer, and this is what it, that ain't all what a probation officer's job. The first meeting is the most important.
Okay.
When you meet me, it's how I determine how I think of you. If you open me with warmth and I see that you genuinely want to work with me, I ain't got no problem with it.
Mm-hmm.
Now, I can't speak for nobody but me, but I've had pro officers that were just straight, but like I told them, what can you do to me that ain't been done to me? Send me back to jail?
Mm-hmm.
And, well, yeah, that's what I can do. You know what? I don't even do this.
Right.
I am to you is a caseload, and like you don't care whether I go back to jail. You don't really care. You don't care. I mean, like, you have no genuine concern for my well-being, period, except whether or not I'm complying with my probation or parole. And you can see that when they talk to you.
Mm-hmm.
I know you're my supervisor. I know you control my life, but I gotta trust you. Trust has got to begin with you showing me that you have something that I'm willing to trust you with. When I come in to see my probation officer, I might have a bad day and everything's going wrong. He needs to listen to me. Let me scream, holler, and shout. Maybe the guy is having a bad day because some things happen. Maybe the probation officer or pro officer could help this guy. And they say, look at some options. Let's do some options. Let's do some scenarios. Why did this happen? How can we avoid it? But
So we look at what this client or person on supervision is talking about. He's talking about there's some key things, you know, somebody needs to listen to me. Another thing he mentioned was, I've got to be able to trust you. And the other that's important is, what do you have that what is it that you have that I can trust you that you can give me? You know, what can you give me? And so those are some key things that this individual talks about. And so we look at some of the core correctional intervention skills that we are having officers learn today and work through a supervision case and individuals that are under their supervision. So we start with relationship skills. Again, they're active listening skills, giving feedback, and a skill called role clarification. All of these skills that officers are learning and working on is to create a collaborative relationship. It's one where they're going to be working together and learning skills that are going to help them to target areas that have continually been what has influenced the individual to go back to prison or reoffend. So with these relationship skills, we move on to what we call bridging skills. Bridging skills are set up to increase motivation. And many of these skills, primarily the intervention skills, are really helpful with individuals with substance use disorder, individuals that are in recovery and working on their substance use disorder and going through treatment and starting to use effective coping skills. Some of the intervention skills are helpful for them to identify what's going on in their thought patterns and influencing and changing those. But before we can even work with an individual and the intervention skills, we have to somehow figure out, are they willing to move forward? And so we do that through the bridging skills where we increase motivation. Effective use of reinforcement is a skill that officers learn to work with a client on to increase awareness on what are the benefits. And so all of these are rooted in motivational interviewing and some of the strategies in motivational interviewing. Effective use of disapproval increases awareness in the consequences of certain behaviors, and repeating those behaviors renders certain consequences. And then you have effective use of authority and effective use of punishment, which are two other skills that we used in the probation community correction setting. So with core correctional intervention skills and officers working on targeting criminogenic needs, the one thing that is really important is that they have to look at the stages of change. And so we look at the trans-theoretical, this is from the it's adapted from the trans-theoretical model of the process of change by Prochaska and DiClemente, and as a starting point to determine what skills an officer will use with someone with a substance use disorder or any other risky behavior. The bridging skills, primarily effective use of reinforcement and effective use of disapproval, are used when individuals are in certain stages, the pre-contemplation and the contemplation stage of change. And that is, you know, for the purpose of increasing awareness with those two skills. So these are for individuals that are just not ready for change. How are we on time? I lost my train of thought on the time part.
Maybe a few minutes left because I know you've got some great content coming
Okay.
up, Cynthia,
So,
too.
so I have just this, this next slide is an example of what officers are doing that are being trained in this area. And this recording is on effective use of reinforcement and how an officer is working with a client.
So part of your probation was to attend treatment, and you are almost done with your treatment program at the Guidance Center, and you've attended every single group and you haven't missed one. So I'm really proud of you for that. That's awesome. I'm glad that you've been attending and that you're almost done with groups. So tell me what your motivation was behind that, and like, why did you keep continuing to go to group?
My motivation was just taking care of myself mainly. Remember how when we started, I told you that I was going to start looking out for myself. That's the main motivation, is myself, you know, just being there. And I really wanted to participate, because even when the group started, it was like a different instructor, and then it switched to Mark, you know, and that was kind of cool because Mark is a really good person. I liked him. So from that moment on, it inspired me and like to be there, you know. I wanted to be there every day. I was like, I'm not gonna miss a class unless I'm sick or something big.
Yeah, sure.
But it wasn't on my schedule, and just knowing that people like that they're aware of what I'm doing, it makes me feel really good.
Good. So what do you see, like, when you look back at it or you think about going to group, what were the immediate benefits of going to group? What were things you felt or you experienced in the moment after going to group?
The main purpose, my sobriety.
Okay, your sobriety.
It kept me focused. It kept me on task. It kept me sober, you know. And every day I went, I learned something new every time. Whether it was about like relapses or about building relationships and like trusting people and family, and just the types of like about my health, like how bad these drugs are to me, you know, or to people. And
Cool.
I've learned that they're bad, you know. And I want to stay away from it. I want to stay away from mainly alcohol too, because a lot of my peers there are for alcohol, and I just seen them. I'm like, dang, you know, it looks bad.
Yeah. So it sounds like what I hear you saying is that you kind of got some immediate insight to your sobriety and what maybe these drugs were doing to your health, and you know how they were making you feel, right? And so what are some other benefits that you saw from going to group?
It's made me consistent.
Okay, give you some consistency.
Yeah, and it's made my mind, like I got some mind power. And just like it helped me realize the path I was taking was wrong, you know.
Yeah.
And it's made me gain a new path that I'm working on.
Give you some better perspective.
Yeah.
Okay.
Yeah.
What else, like, and think about too in terms of maybe probation, like what is a benefit of going to group?
About probation?
Yeah, like how does that affect your probation when you go to group?
I think it makes me look good, and you know, I think it. Well, just like even the class I'm at right now, it's just like 2 or 3 of us. So like I guess participating, like conversating is half of it. She's like, it's a big part of the group, or else it's just gonna be quiet.
Yeah.
So just participating and knowing that like like the instructor can tell you like, oh yeah, he's doing good.
Yeah.
That also is like a good thing that I got
Cool.
from it.
Good. So if, so now let's shift a little bit, I guess, and think about more long term. So now you've come pretty far through the program and you're almost done. So part of your
So I think we get most of the gist of how this works and what officers are doing with the skill. I didn't want to go too far into the program today. I wanted to just touch base one last thing, which was to just quickly go over what the cognitive behavioral chain is, which is what the cognitive behavioral model skill is based on. And this is really, like I said, another training in and of itself, but these are the components of that. And the main thing is that the internal response, the red one in here, the internal response is really the key where we do most of the work. And that is that everything outside of the individual, occurs, there's a situation, but how that person thinks about the situation is what's important to be able to change. So for every, antisocial thought, attitude, or even a belief, there's an intervening thought that a person can replace that with so that there can have some different behaviors that result from the way the person thinks, whereby outcomes are different, So I know that's not very in depth, but I just wanted to touch base. Is that something that we can talk about in another training, or if anybody wants to go into more detail, they can always email me and I can give them some information. But thank you very much. That's my presentation, and we move on to our MC.
Thanks so much, Cynthia. You can go on and stop that screen share, and great presentation. I think the use of real life examples really helped drive some of those points home. So thank you for sharing that. I will ask, just so we can catch up on time, if you have questions, maybe pop those into the chat, or wait a bit. Our case for today does exist on that interface of the corrections system. So there might be some good conversation points you can bring up in that discussion. I'm going to ask Echo IT to share our slides. I have a few quick announcements from the Be Well Texas program. If you're unfamiliar with it, Be Well Texas is a welcoming environment with caring professionals ready to help people start or continue a journey towards recovery. This group is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide, Carly. Our Be Well Texas Clinic provides high-quality treatment for addiction recovery and mental well-being, offering insurance, self-pay, and no-pay options. Lots more information about this. I encourage you to check out bewelltexasclinic.org to learn more. Next slide. You may also find that you want assistance above and beyond what is offered in our regular ECHO sessions. If that's the case, complete an online request form and the Be Well Texas team will be happy to assist you further. And then last slide. I can't believe we're coming up on December, but we are. Our next public safety ECHO is going to involve a didactic on de-escalation techniques for public safety professionals. So please join us for that. That'll be December 8th at 11 a.m. Central Time. With that, we're going to move on to our case presentation for today. Dr. Yatsko, Carly is going to share the case that you submitted and just talk us through your experiences and your questions for the learning team today.
Absolutely. All right. So when I got asked to do a case presentation from someone who's been through our program, I always try and find one that matches what the didactic is. So we have one that arguably is more of a success story. I know sometimes when we do these echoes, it's kind of problem scenarios or cases we're not really sure what to do with. But this is one that I just wanted to walk us through kind of how this patient came to us and her journey with us. And so are y'all seeing page 2? Can we go to page 1, please, of the... There we go. Awesome. So just some questions to plant those before we get into the actual case itself. And so coming from, the public safety side, the community correction side, definitely a justice involved overlap with this case. So some things to think about is, what support info, education to do those in public safety roles need to be able to know or have to be able to create handoffs if nothing currently exists. Because we're going to talk a lot about kind of collaboration and support in this case. We also kind of want to throw out there of like what concerns are there for allowing a patient to remain and utilize outpatient services rather than potentially going inpatient or into more secure facilities, as well as kind of general viewpoints of those in public safety roles when it comes to mood treatment. So medications approved for opioid use disorder, because obviously us coming, primarily from a healthcare side of things, we are very on board with medication-based care. It is the evidence-based and the standard. But I also have a background from the criminal justice side that I know there is some hesitancy sometimes with embracing that component of things. So the patient that we're going to talk about today is someone that presented to the emergency department. So we're going to talk about a couple of different kind of public safety connections that our program has. So we are the UT Health Heroes program, and we really are looking at kind of emergency responses and very immediate access to care and creating some of these on-demand connections for treatment and utilizing partnerships that we have with the emergency department, with first responders such as the Houston Fire Department, their paramedics, as well as the Houston Police Department, their narcotics division and their mental health divisions. We also work very closely with the court systems. So a couple of the courtrooms in the Houston area, we've got a pretty big presence in, and generally, just trying to help connect all those different dots. Because arguably we're all working in that same space, we're working with the same population, but there is a tendency for each of those sections to be very siloed and not collaborate very well together. So the patient that we got did present to one of the emergency departments that we work with, and the emergency department, obviously assessed and acknowledged that opioids were playing a role in the reason that the person had come into the ED, and she was in withdrawal, and they have the ability to both dispense buprenorphine on site, as well as, do a warm handoff with our program to continue services. So helping with that acute care, but then also connecting them to us. And so we got a warm handoff from the ED. They reached out to us and gave the, participants information. And we called, and this was, I will say, it was a Friday afternoon, but we called immediately once we get these referrals so we can touch base and create a plan. And when the patient first picked up the phone, I think she was a little surprised, or she's like, I literally just got out of the ED. I'm walking into my house and now y'all are calling me. Like, this is incredible. Like, I had paperwork. I probably would have followed up next week, but like, here you are, like trying to make a plan. And so her and I chatted for a little bit, and then we got her set up so that we could do an intake. We have the ability to do virtual intakes and virtual medical consults to kind of, take it to that next step of treatment. So we set that up. She was able to, connect with us via WebEx. She was able to meet our prescribing physician so that we could make sure that she had medication continuing from the dose that she got in the ED. And then basically created an entire plan of what was going to come next. Because again, everything we do is very comprehensive care and wraparound services and all of the different components that we know often go hand in hand when you're dealing with substance use. So background of this person, she was employed part-time. She did not have any insurance or any access to care, which is why, of course, she probably found herself in emergency department seeking assistance when she was in withdrawal, because she didn't have any other kind of connection to get assistance in that realm. She was justice involved, and she had, a couple of mental health encounters in the past, currently on probation for a DWI case, so substance related case, and started 2-year probation in the fall of last year. And she was stipulated at the time of that review to have inpatient residential for a period of time, parenting classes, kind of the usual realm of things from the PO. And she had entered residential treatment at the end of last year, but she only stayed 9 days, took herself out of there. And then fast forward a couple of months later is when she ended up in RED and connecting with us and trying to get, help with really creating that change. So at this point, she was now ready to do something differently. She wanted to be able to find some stability and to get things back on track. She had a lengthy history of opioid use, regular use, was very scared to withdraw cold turkey because she's done it before. She knows how uncomfortable that is. And she did not have at the time any mood history. So she had not been connected to medications for OUD And so she was not as familiar with that being a tool that she could utilize as part of her process. So of course, we were able to really explain what Suboxone was, how we utilize it, the benefits both for acute withdrawal, but as well for long-term, cravings, and helping, really create that stability and consistency while her brain's healing from, her period of active use. And so we were able to definitely, kind of get her plugged into a new component of care that she had not utilized before and had not really been directed or recommended to utilize before. Had she gone to a different emergency department, she might not have been able to get treated that way, been able to be connected with us, but we were very grateful that she did end up, on our radar, and were able to support her with a plan moving forward. So strategies that we employed, of course, that immediate enrollment in a medication-based treatment, getting her out of active use, getting her safe and stable, and then providing comprehensive care. So we have a very diverse team, many of which are on this call with me right now. Thanks for the support, everyone. So we have peer recovery coaches, so of course, those with lived experience, counselors, physicians, patient care coordinators, social workers, and we do a little bit of everything to support our patients, but absolutely when they're justice involved, we play a big role in probation and court support. So we can jump ahead. Perfect. So some of the barriers here, of course, is in this particular case, we did not have a partnership with the court that she was in or familiarity with the landscape that she was in. Of course, generally we're aware of probation and courts and how they all function, but there is definitely a very different culture depending on, which courthouse you end up being in and, which probation officer you end up working with. She, of course, was a single mother. She has 6 children, 3 of which, under the age of 10 that were currently in her custody. Part of that was where she had reported it was a struggle to stay in residential-based care because she felt, as a mother that she was trying to get out, do the right thing, be there for her children. And so that was something that made it harder for her to go residential. But when she had been with us, so at this point, she had been with our program for about 4 months, I think, since that ED referral. She had been coming regularly for medication, for accountability, urine drug screens, going to groups, meeting with counselors. She's been very active and engaged. And the lovely court system, as much as we know, is not always very quick. And so she was having a review at this point, and part of the review was for a failed urine drug screen that had happened many months prior for a marijuana tox screen, which coincided roughly about the time that we enrolled her. So of course we had gotten, we're able to help her get the opioids out of her system. We also know that marijuana can be another barrier. It also takes a lot longer to get out of your system. So she had that, positive tox screen for marijuana many months prior. Since then, we had not seen anything on her urine drug screen. She was coming in regularly, nothing else that was concerning. So we had done very well in making sure that everything was substance free so that she wouldn't have any more holdups in the justice system. She went to court, and unfortunately, there was a couple of things that didn't line up for her that day. The regular judge that she'd been seeing was out, so they had a sitting judge that was in there. So the sitting judge was not real familiar with the patient's history, was not very familiar with us and our program and the things that we were doing. We did have one of our peer support specialists in there, so we had a recovery coach there as well. But that judge was very adamant that you were stipulated to residential. It doesn't matter that you've been doing very well in outpatient for many, many months. Like, you didn't follow the rules. We're going to send you to a secure residential facility. So they were going to send her to the HUA in the Houston area. And, of course, the lawyer was advocating. We were there to support and advocate. And ultimately, they were able to convince the judge to not send her to secure residential and give an opportunity for her regular judge to return to really review where she was at. And so they did decide that they were gonna, take her into custody and lock her up until she could then see her regular judge, but they were not gonna send her to a secure facility yet. So they at least did kind of give that, benefit. And when the regular judge did return. There was a conversation. Our peer coach, Kelly, was in court that day. Of course, they were not familiar with our program, so she had an opportunity to stand up, explain who we are, what we do, our relationship with the patient, all of the progress and success that she had had in the many months that she'd been with our program for outpatient, and ultimately was able to, let them see that she really was doing well and that a secure residential facility would be a step back for her at this point. And so it really was one of those very positive outcomes where we were able to advocate, where they were able to see that, hey, outpatient is working, medication-based care is working. Here's all the things that are, successes about her journey. And they basically stipulated that she remain active and engaged with us, that she would have so many encounters with us every week, and was very on board with kind of allowing this progress to continue. So we were really excited to see that outcome. Some of the things that could have gone, better or worse, if there was more familiarity with this particular court, then maybe we could have avoided her having to be locked up for that week. Well, there was kind of some indecisiveness about what was supposed to happen, what a regular judge wanted to do here, because there was not any rapport that was built there. We have a much closer relationship with some of the other courts in our area, like the drug court and the reintegration court. And so there's often much more conversation and collaboration back and forth, which is something that we're really grateful for, because I know at the end of the day, we have the same goals and we're trying to, support patients to be able to be successful and to do it, as we're working together and not working against each other. So we really, it could have gone better, it could have gone worse, but ultimately we did have a positive outcome here. And the biggest thing that we've, seen is that those types of collaborations, when we're in courtrooms that understand addiction, that understand medication, that understand treatment, we tend to see, a lot more of a fair assessment of whether someone is able to, manage in an outpatient setting versus some places who still do not have a lot of that insight or knowledge, or have not worked closely enough with addiction or with treatment programs to really know. So in this case, luckily, we were able to advocate. And now, of course, there is familiarity with us. And moving forward, if we have patients in that court, there's just already that groundwork laid for future kind of assessments. Referrals we made during this one, obviously, we were able to get her connected to medication very quickly, both with the dosing in the hospital as well as with an ongoing plan with us. Generally, we are just a bridge program for medication. We write them a temporary script and then we plug them into the community. So we're just filling that gap. In this case, we are also partners with the UL Texas for offering Texas Mood state-funded OBOT-based treatment. She met all the eligibility requirements for that, so she was able to stay in-house with us and meet with our prescribing physician on a regular basis. And so it was really able to do kind of one-stop shopping. We're giving her clinical and behavioral care, we're giving her medication-based care, giving her all the support and things that she's needing. And I think that's probably a good overview, and that leaves some time for questions, comments.
Yeah, terrific overview. Go ahead.
Myself and my team, I've got a lot of my team on here, so any questions you throw at us, someone's going to be able to answer for you.
I like that, and I appreciate you bringing a success story to the group. I mean, they're valuable to learn from effective strategies, and I think as a reminder that successes do happen. I'm going to open it up to the audience. Any questions for Andrea and the rest of her team about this situation?
So I will go ahead and circle us back then to some of the questions that we put at the top of our presentation. And I think I'll start at number 3, because I'm definitely very curious. I know there are a lot of people that are on the PO side, or, just based on your introductions in the chat. Where are people falling with mood treatment? Are they supportive of it? What types of barriers do y'all see? Because if you're working with patients, even if you're on board, like, is the culture in your particular office on board with that? Like, definitely curious, because in our case, we of course had a patient had never utilized mood before and had struggled arguably to create any consistency before. And we were able to see that that was a huge component of her being very successful in this realm, and it was by chance really, though, that she ended up in mood treatment and not directly referred to us by either the court or her PO or anyone else involved. It just, she happened to walk into the right ED looking for help, and we were able to be there. So I'm just always curious kind of what the landscape is out there. Is it getting better? Is it being more embracive of, you know, medication-based care? Any feedback on that is appreciated.
It's Dr. Miramontes. So I noticed we were talking about how we can do mood in jail, pre-trial, and hopefully getting them better. So then we go to trial, we can tell the judge, hey, look, they're in treatment, they're doing better. Why don't we consider this for a diversion from the justice system, right?
Mhm.
So our jail doesn't. And they actually, I said, well, why not? This seems like it would decrease violence in the jail. It would decrease utilization in the jail of healthcare resources when they're detoxing. It probably make them a lot easier to live with in jail, right? If you're not detoxing. And so I asked them that, and they said, well, if we start someone pre-trial and then they get convicted and sent to prison, they won't get Suboxone or methadone because it'll be stopped. And so they're so afraid of that contingency in a portion of the clients they serve that they don't start for everybody else. So I thought that was kind of interesting that thought process came into mind. Obviously, I kind of understand their logic, but knowing in the correction system that the majority of folks are going to get bailed out, they're going to go out on probation, they're going to have an adjudication later on in months, years from now, whatever. Seems like it's silly not to start the process and the rehab and the stabilization while they're incarcerated.
I agree with that. And we get a lot of patients who come to us who are justice involved, just inherently with a lot of our pathways and high risk needs. We get a lot of patients who, you know, come to us already kind of in the system and at different phases in the process. And, you know, one of the biggest things that we always just are big advocates for of like, all right, when's your next court date? How much time do we have? And how many, you know, positive things can we add to this list before you have to be in front of a judge again? So yes, you know, there's crimes, there's consequences, there's things, but now we have some time and we know the system can be slow, but let's use that to our advantage. So, you know, let's make sure that we're doing well, that you're maintaining sobriety, that you're working towards, you know, all these other things, that you're getting a job, that you're repairing, you know, relationships, so that when it gets to that point and there is a review, it's kind of like they had a trial run of, hey, we've had a few months and now I'm back in front. What can I show for that? And so we're all about trying to give them that, just like you had said, that pre-opportunity. If we've got a window, let's maximize our involvement so that we can create a positive outcome. So when it is reviewed by the system, then we've got something to show for their time and their effort prior to that, you know, hearing in front of a judge.
So we're running up on time because, Cynthia, because this case really does dovetail with your didactic presentation. I wonder if you might just share your thoughts on it, maybe some of the key takeaways you have.
Sure. Yeah. Yes. Just really quickly, I think to answer Dr. Yatsko's question is, it's across the board everywhere. It really depends on how caseloads are you know, specialized, and if the officers have that knowledge. But just to take away some things from today is that I think it's important that the relationship's got to be a collaborative relationship, that you know, clients and people on supervision want to be listened to. In order to have somebody change, you have to know where they're at in the process of change. Are they willing to change? If not, then the purpose is working with them to increase that awareness. I think those are some of the key things that I was trying to bring across with probation officers as they work with them. So if you intervene in the right places, you help individuals increase awareness, you help them to be in a way where they can change, and we can avoid recidivism.
Yeah, and I think, Andrea, the case you presented really demonstrates the tremendous opportunity for success if you have more of those warm handoffs, more of that advocacy, more connecting and working together. I can't believe it, we are up on our time. I'm going to turn now to David. Can you give us a wrap up from today, just key takeaways that you have from didactics and the discussion?
Right. So we heard today that treatment in the corrections environment helps for successful rehabilitation of those that have offended. We heard that cognitive programming is really helpful along that journey, working with antisocial attitudes, beliefs, fears, and patterns of behavior. We heard that motivational interviewing skills are key to building that relationship with the client. We heard that finding the carrot was, we actually heard that from the 2 case examples, right? And we heard that active listening, trusting your officer or your counselor. And the big thing we heard is, what can you do for me? How can you help me to be successful? I think we heard that a couple of times. And in the case we saw how there could be a disconnect from the medical model, what we know works, and the legal model, which may not understand the intricacies of medical treatment for substance abuse and opioid use disorder. So I think we got a good overview in the corrections world of some of the things that they're doing, and a good case that kind of dovetailed on that, on how we could be more effective by integrating with the legal system to help our clients succeed and then be returned to the community, rehabilitated, and hopefully so they don't offend again.
Awesome. Thank you so much. I want to thank you all for joining today's ECHO session. Check a little earlier in the chat for that survey to give us some feedback and get your CE credit and enter that drawing to win a $30 Walmart gift card. Thank you very much to our hub team for joining us, Andrea and your team for presenting on such a great case. And above all else, to all of you for joining us to learn together. We want to see you at our next ECHO session on Thursday, December 8th at 11 a.m. Central. Have a great rest of your day.